Hello, I'm Dr. Sridhar Kalyanasundaram, consultant neonatologist and pediatrician. Welcome again to my channel. Thank you for subscribing and keeping notifications on, and I hope you'll be able to share these videos as well. As I have mentioned earlier, I would request you to go through the different playlists, especially the playlists related to safety, and there are playlists related to feeding, complementary feeding, and so on as well. In this video, I'll have a few simple tips for new parents on common conditions that may be a bit concerning for the parents but are in reality not a serious concern. So this particular first problem is erythema of the newborn. So when the babies are born, they often have a white cheesy covering on the skin called the vernix, which often goes off over the first day or so. The erythema starts as early as the first few hours, and then it increases over the first 2 to 3 days. It may appear quite prominent in some babies. It affects almost all parts. It starts on the face and chest and abdomen. It can affect the legs as well. And it's usually more prominent in the fair-skinned babies. So there may be just white areas in the middle with raised eruptions called papules. There may be surrounding redness. Even though it looks scary, a baby looks well, baby is feeding well, is active, and when a pediatrician assesses, they will invariably reassure you that it's nothing to be worried about. In some babies, redness is not as prominent, and especially in the dark skin babies, the pustules may be more prominent. We sometimes call it neonatal pustulosis. This is a benign condition as well. So this is something that you can be reassured about. The second problem is not exactly in the newborn period, but it happens after the first 3 weeks or so. So almost all the babies receive the BCG vaccine in their left deltoid or the shoulder region, and when the BCG, which is a live attenuated bacteria, reacts in the baby, our own immune system responds and causes a reaction there. So this reaction takes a form of bleb or blister, which breaks and then a small scar forms. So this is the sequence. So the injection is given actually into the layers of the skin. It's an intradermal injection. A small raised peel happens on the first few hours, and the next stage is what we discussed as a 3 to 4 weeks post vaccination. In some babies this takes time, even 5 to 6 weeks, and after 6 weeks it becomes a blister which breaks. Sometimes the blister breaks, seals, breaks again, and this may happen 2-3 times. In very rare situations we get complications like a BCG abscess, which can be a big swelling which may need draining, and you may also get swelling under the armpit, which is due to a reaction of the lymph node in that region. So this is called BCG lymphadenitis. So both these problems may need review, but these are very, very rare situations. So there is a very tiny scar in that area. Many parents are worried about the scar, but the scar actually is very tiny, and you don't need to worry about that. Usually we inject only in this region due to the WHO convention, and it's easy to recognize which child has received BCG by just looking for the scar there. Also, the immunogenicity has been more definitely demonstrated by injecting in the thin skin in this region. So injecting it into the buttock or the sole of the foot doesn't make it guaranteed that the reaction would be similar. The third concern is the caput and the cephalhematoma. The caput is almost universal in a vaginal delivery because the scalp has a thin layer and the fluid into the layer is called a caput, and that usually resolves over 2 to 3 days. In some babies where there is a vacuum delivery or the delivery has been a prolonged process, the caput may be quite prominent, so you may have an elongated swelling on the back of the head or the presenting part. The cephalhematoma is actually a little more significant in that there is a small bleed over the skull bone covering. So it's between the skull bone and its covering membrane called the periosteum. It's limited by this bone margin, so the periosteum holds it, so it's fairly firm and it bulges out like this, and it feels like a soft spongy swelling. It's not too spongy, it's a firm swelling, and when we press on one side it can be felt on the other side, and that's called fluctuation. The main significance of the cephalhematoma is that it doesn't cause any harm by itself unless it's a very large one or there is a risk of traumatic injury. We don't need to do an ultrasound or any imaging, and skull fractures are very, very rare to be associated with it. and the main significance is that because it's blood which is collected there, there is a higher risk of jaundice from the blood being broken down and absorbed. So these babies would need to be monitored for jaundice. Sometimes it's present on both sides as well. However, it doesn't impact the baby in any way. Another important point that the parents have to remember, that it takes a few weeks to settle down. So blood has to absorb, it hardens. So you get hard area with surrounding liquidy area, and then the slightly hard area may persist for even a few weeks to months, and then gradually it resolves. This is a more serious problem. It's called a subgaleal hemorrhage, where between the muscle and the surrounding membrane we get a larger bleed, and because this area is loose and usually the bleed happens from a artery, it can bleed significantly. It's a very rare problem, and if you notice a very boggy swelling on the scalp, please inform the nurse or the doctor to review that, but it's very unusual. And this is just to show you the layers of the scalp, so the bone and the surrounding periosteum, then you have the aponeurosis under which the bleed happens in the subgaleal bleed. So this is the third concern. Caput, no concerns, it's just fluid. Cephalhematoma, small blood collection, and it absorbs over time. The next important concern that the parents have is the umbilical cord related changes. So the umbilical cord looks basically like this at birth with a clamp. The clamp is mainly because the bleeding shouldn't happen from the vessels from the baby end of it, and it's usually applied about 1.5 inches or so away from the skin. The clamp usually doesn't hurt the baby, and you don't need to be worried. It tends to separate from this part and it falls off by 5 to 7 days in most instances, but in some babies it takes time. If you have used antibiotics on the baby for any risk factors, or if we have been using alcohol from the beginning, then it may be delayed in separation, because we need the normal bacteria to colonize this, and then it separates and falls off. Where the bacteria have been eliminated due to various factors as we discussed, it may take time. So it dries and shrivels, so we prefer to keep the nappy folded below the cord. It shouldn't cover it, because the nappy is fairly tight material and it doesn't allow much air to get in. If air doesn't go in and it covers the cord area, it may start smelling. Also, more moisture is retained, so it doesn't dry up as it should, and so the separation process is delayed. It becomes soggy and it may break off in an uneven fashion. So better to keep the nappy folded from the beginning, and the nurses in the hospital are taught to explain this to you as well. Once it dries up, it starts pulling on the edges, and that's where it separates, and it falls off in a few days. Some babies, you may have a little prominence called umbilical granuloma, which is a remnant of the healing process. So when it falls off, it may have a little soggy area at the bottom like this, and as it's illustrated here, you have a thumb on the top part and the fingers on the bottom part. Spread it apart. These two edges may stick together with some gooey secretions. You can use alcohol swab at this stage. So normally we don't recommend using alcohol swab or powder or anything in the early stages, because it delays the separation. But when it is actually starting to separate, you may find stickiness around it, and you after it is separated also, you open it and clean it with alcohol swab. Even if an umbilical granuloma, which is a pink remaining swelling, stays, you can continue to clean it and observe. As long as this area is dry, you continue to keep the nappy folded below, and once it is dry, you can start covering the cord area. Bathing can be done at any stage. However, we prefer to wait till the cord falls if it is suitable. If you are bathing before the cord falls, you try to dry the cord area quickly so it doesn't stay wet, and avoid oil or moisturizer applications over the cord itself. Once it falls, you can start treating like normal. So cotton tip can be used to wipe that area, or alcohol swab can be used to clean as well. So the last part is again related to the umbilicus. So umbilical herniation happens because the umbilicus is a gap. So sometimes if the muscle doesn't get close to it, so there is a gap, and the intestines actually can bulge through it. In the first few weeks, the babies are obviously a bit colicky and they may cry excessively. So this increases the pressure inside the abdomen, causing this to bulge out. And because the area is lax skin, it bulges out like this. It can be wide or it can sometimes pout out, and it's a benign condition, so it doesn't need any treatment. It can stay in some babies, especially the larger ones, for even 1 to 2 years of age, but it doesn't obstruct because it's a lax one. There is no risk to the baby. If you push on it, it will go back in, but the moment the baby strains or cries, it comes out. Some communities put coins and bind towels around it, but it is not necessary, because even if you do that, the gap in the muscle isn't going to change. So essentially, when the baby strains, it will come out again. And obviously, reducing the colic, avoiding overfeeding and things might be factors that might reduce it, but if it happens, don't worry about it. And one hernia which you would worry about is inguinal hernia, where actually in the groin you would see a swelling arising like this, which may come down to the testis in a boy. So in a girl, it's very rare to have an inguinal hernia, but it can still happen, though it doesn't descend. It stays in the inguinal region. So if you see it in the groin region, a bulge like this, it's an inguinal hernia. That's more important. You should take the baby to the pediatrician. So I hope these tips are useful, and please review the other videos, and don't miss the life support videos if you have not watched them. Thank you.